I'm going to start by showing a short video, so we're going to. This is a video that was put together in Maine. So it was actually, I believe, like a news item on loneliness. You can find it on YouTube. As I said to you the first time, actually, the absolute best YouTube videos on these issues come from the UK. Nonetheless, this is a very good video that we looked at and gives us some information, and then we'll start our presentation.
A new finding from the National Academies of Sciences, Engineering, and Medicine finds that about a quarter of Americans 65 and older are socially isolated, and more than 40% say they feel lonely. COVID-19 has highlighted these issues, especially among seniors, and our Chloe Thibault is here this morning. She's been following this and how much of an effect loneliness can actually have on someone's physical health. Good morning, Chloe.
Hi, Sharon. Good morning. Yeah, research shows that prolonged social isolation and loneliness can have adverse health impacts comparable to smoking 15 cigarettes a day. It's a serious issue that's getting nationwide attention.
Every now and then I miss tactile sensation. I'd like to give somebody a hug.
84-year-old Beverly Kelly says COVID-19 hasn't changed her life much. She just misses her family and wants to hug the people she loves.
It's what gives our life meaning.
Eleanor Rennie is on the same page. She's 80.
I think you have to reach out to other people. Otherwise, you just get so isolated that it's not the way life is supposed to be.
On Thursday, the Senate Aging Committee held a hearing to discuss the importance of social interaction among seniors, especially in light of COVID-19.
If seniors are isolated for a long time and don't have human contact, that they tend to develop serious health problems.
Senator Collins says those problems include an increased risk of stroke, heart disease, Alzheimer's, and depression. When it comes to COVID-19's impact,
it's worsening the health conditions that are caused by prolonged isolation.
That's why seniors are encouraged to reach out if they're experiencing signs of social isolation, like feeling sad or bored, being withdrawn, or not enjoying their life. But the responsibility can't just fall on them.
Family members and friends need to make a special effort to keep in touch with seniors.
Because Mainers are resilient, and sometimes it's hard to ask for help.
I think people just have to realize that it's the time that you should be really good to other people that sometimes you just take for granted.
Now, a committee with the National Academies of Sciences, Engineering, and Medicine has come up with some solutions to address social isolation. Those include improving awareness among the healthcare workforce and the public about social isolation and strengthening ties between the healthcare system and community networks or resources. Live at home this morning, Chloe Thibault, News Center, Maine.
A new finding from the National
Okay, so last week we covered quite a few pieces of information, and I'm assuming that everyone has their workbooks. We emailed you copies of the workbook, which is in a PDF format, which is this document right here. So you should all have that. We would have sent it to you before, and so we covered issues such as our human needs. We covered issues around physical, mental, social, and spiritual needs. We went through the basic visiting advice. Now Catherine is joining us, so good news. And the My Story Matters. So what we're going to do is, now that Catherine has joined us, I'm going to ask Catherine to say a short prayer for us, and then we'll begin our presentation tonight. Catherine, can you unmute?
Yeah, I'm just going to go to a little quieter spot here. Just a sec. I'm glad you all could come tonight.
Perfectly well, yeah.
Okay. So, let's go ahead and say a Hail Mary in honor of Mother Mary and her guidance this evening. In the name of the Father and the Son and the Holy Spirit, amen. Hail Mary, full of grace, the Lord is with thee. Blessed art thou among women. Blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners, now and at the hour of our death. Amen. In the name of the Father, Son, and the Holy Spirit, amen.
Thank you very much, Catherine.
All right, so this time we're starting off with communicating with people with disabilities.
Now, can everyone see the screen fine? Because I do have my screen sort of set up funny right now, but does it look fine on your end? You can sort of put your finger up if it is.
I can see
Or
it.
do I have, you can see everything fine. Good, excellent. And so this would be the beginning of chapter 4 in your workbook if you want to follow. Obviously, we're not covering everything in the workbook, but we're covering the basic information. And we want to leave time at the end for discussion and questions, but also if people have experiences that they want to share, that's also very good for the rest of us too. So Genevieve's going to start talking about communicating with people with disabilities.
Yeah, and this is on page 21, so if you're looking for it, that's where it starts. So some communication tips is just don't make decisions for others. We spoke about this last week a bit, but people with disabilities or seniors just in general are sometimes looked at as children or spoken down to as children. And in that same way, a lot of decisions are made for them. But it's important to make sure that everyone gets, they're treated as adults, so they make their own decisions because everyone has preferences. Speak directly to the person, and avoid disempowering words, and be very sensitive about physical contact. A lot of people in the disability community have been touched almost more than the average person just because they have been seen more as children. So it shows respect by keeping the physical contact lower than you might want to. And also ensure that the environment you're visiting this person in is quiet and comfortable.
So basically, I know a lot of people in the disability community because of my work with the euthanasia prevention issues. And they really do find that their space is important to them. And a lot of us, we look at someone with physical needs and we sometimes see them differently than they actually are. But on top of it, a lot of us might just want to be helpful. And we're not thinking that this is somebody else's space, right? And so we're not thinking, for instance, of someone's wheelchair as their space, or we're not thinking about these things in the way that they are. So we have to realize right off the bat that we, as Genevieve's talking about, how we respect the person is very important for communicating to them. Yeah, it's down here, Jen, right there.
All right. So you might be visiting someone who's on the autism spectrum. There's things to avoid, such as humor and sarcasm. Often people with autism can't pick up on the humor or especially sarcasm being used. They understand a lot of times that it is sarcasm, but they do not know what you're trying to tell them through it. So it's better just to avoid that. Use simple and short sentences, just so it's for better understanding and easier processing. Close questions, so yes or no answers. And be aware of body language from their side. You can pick up on how comfortable they are or if they feel trapped in a situation, and also what you're showing them. And also use flexible words. This just helps with having them, again, feel not trapped in a situation. You may also meet people with chronic medical conditions. Remain calm and use unhurried tones. Ask the person if you can do anything to help them. Everyone knows the best way to be supported for themselves. Don't just jump in and help them in a way you think they need help with. Always ask them. Also, if they do need help, you can ask them the best way to access support for them. It could be another staff in the building, or if they use some sort of other like technology. And always tell them what you are doing when you're with them, just for better communication. People with hearing difficulties, let them know if you can't understand. You might feel like it's being rude if you ask them to clarify what they're saying, but typically they know their own strengths and weaknesses, and they probably will appreciate it more if you clarify with them than just assuming what they're saying. If there is a sign language interpreter, look at the person you're speaking with and not at the interpreter. That person is there just to help with communication, not to be the one communicated with. You can rephrase things instead of repeating them. Oftentimes certain things when you're talking to them are not picked up specifically, so you might want to rephrase a sentence to make it easier for understanding. Always face the person directly. Some people in the hearing community read lips, so it's easier just to be sitting right in front of them and not have like a glare on your face if there's like a window or something, and make sure to always speak clearly. People with learning disabilities, you typically won't know if someone has a learning disability that you're visiting with, and it also might not really affect visiting them in general. But if you do know, or if you do notice that they're struggling with communication, just remember to use short and clear direct sentences or rephrase your information. Some people like visual aids like cue cards or different pictures. For instance, if you're asking them about their past and they might be struggling with a memory, you can ask them to take out some of their personal photos that might help them remember things, and provide opportunities for to answer questions for them and yourself. People with mental illnesses. Again, a lot of times people with mental illnesses, you may not know they have one. And also this can cover a lot of things such as like depression and anxiety to things like schizophrenia. If a person you are visiting with seems to become upset, just remain calm. Remember to keep yourself protected if you think it's getting too far in an emotional sense, but also typically they know themselves and they know what to do for themselves as a calming mechanisms. Allow the person to talk. This is the same with all visiting. Show empathy, especially if they're talking about their mental illness. You may not understand what they're going through in their experiences of life, but just show compassion towards them in their past and what they just go through every single day. Accept the reality as their own. This could be for someone who has schizophrenia, but also never like go along with it. So if they are hearing something and they might mention it, do not agree with them. If you do not hear something or see something, then simply let them know. It helps them know what reality is. Use short and clear sentences. This again goes along with everyone you may be visiting. And also know who to access for support, if that's staff or if it's someone to call. And always, again, tell them what you're doing and where you are in the room. People with mobility issues. This may be more of a common person you may be visiting with if it's someone with a cane or a walker or a wheelchair. People may have needs that are related to their mobility. And like walk with them slower if you're going for a walk, and refer to their wheelchair in a positive manner. A lot of times, you know, we mentioned this last week, they see the wheelchair as a part of them instead of a separate thing. So always just refer to it, positively.
Well, the prime example is that often people say so-and-so is wheelchair bound. So they're creating a negative connotation to that wheelchair. And yet the person in the wheelchair, this is how they get around. This is their mobility. This is part of how they, do things. So we don't use terms like wheelchair bound. We would use uses a wheelchair. Just the same way as when we're referring to disabilities. Someone will say, oh, that's a such and such. No, that's a person Like they're all persons. We talk to them in that person manner first. And in the same way, when we're talking about someone with mobility issues, we do not use the negative language that you hear all the time. And I see that in even in pro-life articles, you'll see that when someone is using these terms which are negative, and they're not using it on purpose. They're using it because that's what they see society using, but it's really not acceptable because it's putting somebody down. It's making them feel down for their reality, right?
Yeah. Also, when it comes to wheelchairs, never just start pushing them in their wheelchair. Always make sure to ask them if they would like you to, or they might even ask you to like push them down the hallway or where it is, but never touch their wheelchair unless they tell you to or give you approval to. When you are visiting with them, sit at their level, just show respect so they don't have like a power over if you're like sitting above them or standing beside them, let's say. And be aware of the person's reach limits. Obviously, this could also be people who are not in wheelchairs or walkers or things like that, but just in general, a lot of people when they're older can't reach as far, their mobility is just different. So if you have something when you're visiting that you're sharing with them or they're sharing something with you, help them by having that close in their reach limits. And yes, don't push the person's wheelchair or touch it. People with speech difficulties. Don't assume that they can't understand. Oftentimes, when you're speaking with someone, you kind of just, you decide what they understand based on how they speak to you. But in most cases, people know a lot, can understand a lot more than what they communicate back. Be patient with them. It might take them a lot longer to answer you. So just don't rush them, give them their time to say something. Ask questions that require short answers. This could be yes or no, or just something that doesn't take a lot of detail. Be attentive and don't pretend to understand. It's similar to the hearing. They know their strengths and their weaknesses. So if you ask them to clarify something they said, they will more than likely feel completely fine to and will appreciate that you're trying to understand them. And be open to different ways of communicating. Some people use iPads that have apps on it that you could, like, it'll speak for them, or just typing, or if it's writing in a notebook back and forth. We're there to communicate and visit with them, so we should help and be attentive to all their needs. People with visual difficulties. Before you enter the room or when you enter the room, make sure to identify yourself so they know who you are. If they have a guide dog with them, walk on the opposite side of the guide dog and do not touch it. It just distracts the dog or the animal from their job, and we don't want to do that. Describe what you're doing at all times. They might not be able to see long distance or very far, so they don't know what you're doing. That could lead them to anxiety or just feeling uncomfortable in the situation. Give specific non-visual information. And offer to read written information to them. You can also ask them how their visual difficulties are. Some people can read something really close and some cannot. So just ask them about their limits and provide large print if necessary and if it's applicable to the visit.
So I was going to talk a little bit about, before I get into advocacy. Now, advocacy is not everybody's thing. Now, a couple of you joined a little bit later, so we did show a short video before we got started. And for those who did join a little bit later, you'll notice that if you look at the video later, you notice we did go through a little bit of a recap, not much, but a little bit of a recap of the first session. But I will tell you a little bit about people with speech difficulties, because there's a woman I know, and she's a year younger than me, and a few years ago, she had a pretty substantial stroke. The interesting thing is that, of course, she's recovered. She does use a wheelchair, but she's recovered very well, but she still has speech problems because there was a bit of an effect on her brain. And the speech problem is that sometimes she has a hard time finding a word, right? She's trying to think of this word and she'll be, but if you know her well, like I know her, you realize that if you just give her a little bit of time, she comes up with it, right? Because she knows, it's almost frustrating for her because she knows what she wants to say. She's just having a hard time saying it. Now, as for visual difficulties, the president of our group, Euthanasia Prevention Coalition, her name is Amy Hasbrook, and she was born blind. She's been blind all her life, but she has a very little bit of eyesight. So she can't, if she's in a normal sort of setting, she can't really see things. But when you see her making presentations, she's got this this computer iPad type thing. It's sort of yay big, and she has everything blown up into a super large size, and so she's able to communicate and read that way. And that's how she does things. So all I'm saying is there are different abilities that people have. Now, why do we talk about disability? Well, often people, when they become elderly, might develop disabilities. And you might also be visiting someone and they have a disability. So it's important to recognize these issues around disability. Now, advocacy is actually a new program we're developing, a specific program just on advocacy. You know, it's interesting. I get phone calls about healthcare issues all the time, euthanasia issues. I just actually have been dealing with this one euthanasia issue again recently in Ontario. I was dealing with another case just recently of a family whose mother is very, very, very ill with COVID. I mean, she's in the ICU, and they're all concerned about things. But you see, for a lot of people, they don't know how to respond to these questions. They don't have a lot of information. They're not comfortable when they're dealing, especially if you're talking about an end of life question. They're not comfortable with it. So one of the things that certainly I do in my work is I'm often I'm helping people make decisions. Not that I'm telling them what to do. I'm discussing it with them. Often I'm listening is really what I'm doing. But the point of being an advocate also is that if someone has a significant health problem, and I think I did mention this in the previous presentation, but if I didn't, it's clear to me that if someone has a significant health problem and they're getting a little bit older, and or if they have a significant disability, that it's important to have an advocate. And the reason it's important is twofold. One is you're seen differently if you are part of community. You're seen differently if you're with someone. Secondly, the advocate also will listen, have an ability to remind that person, have an ability to also say to the physician, if the physician's looking at someone and thinking that maybe, you know, they're not quite with it, you say, well, you know, so-and-so is actually perfectly well. They need to know about this, you know, to help them, because this is someone who is a friend who knows that person. Advocacy is very important, especially as the culture has shifted. There's a lot of people, though, who have trouble stating their feelings, and they're afraid to speak out. These are the kind of issues. The difficulty with being an advocate is it's not something that everybody can do. You have to be capable of being very polite and very straightforward at the same time. You have to be supportive, and you have to recognize that your role in being an advocate is that you're being with that person, and you're representing that person. And everything you're doing is also recognizing the privacy of that person. Advocacy is very, very important, especially in cases of somebody who has significant health problems and someone starts questioning their reason to live. I'm dealing with a case right now just to give you an idea. I think I mentioned it last week because I'm still dealing with it. It's starting to come to fruition now. And I've been dealing with this case for about 2.5 years of this child who nearly died. This is a young girl. She's a little over 3 years old, and she nearly died of sudden infant death syndrome when she was around 6 months old. But her mother found her before she had, because obviously with sudden infant death syndrome, they stopped breathing, and we don't know why. But her mother had found her before it had been too late to revive her. But you have a child here with significant brain injury, significant issues. There's no question, no one's questioning that. The point is, how do we get proper care for this child? And you may say, what are you saying, Alex? Well, the difficulty is, and it shouldn't be like this, and I wish it weren't like this, but she is seen as someone who shouldn't be alive. You may say I'm crazy. I'm not going to go through the whole story with you based on privacy issues and everything. It's very sad what's happened. And so we're constantly battling for the care of this child. This child's actually at this moment quite stable. She's living at home, but when she's had health problems and had to go back to the, pediatric intensive care unit, there's always been a battle, and we've had to hire lawyers. We've had to do everything in order to get this child care, just care to continue properly living. Now, the problem in the culture is most people would say, why are you doing that? Because you have a child with significant disabilities. Well, you have a family that loves this child, and you have a child that's not dying. You have a child that breathes on its own, who is not dying. And I'm not to choose to kill someone. So I'm a supportive person. So obviously the mother of this child comes to me a lot because why? I agree with her that her child should be alive and be cared for. And I'm helping her. Anyway, why is this important? Well, if you're very elderly, if you're someone who's very elderly and has some health problems, sometimes some physicians or some nurses might also look to you in a similar way. And people with disabilities also experience this. Why? Well, people with disabilities have conditions that can't, how would you say, certain disabilities, of course, are not going to improve. That's just how they are. They have a disability. This is how they are. So a lot of times they're seen as a frustrating case. A lot of people look at them in a different manner than they should. They need an advocate who stands up for them. They need community that stands up for them. So what are we standing up for? We're standing up for their rights. We're helping them receive the proper care that they deserve. And also we're making sure that they're receiving the information they need. So let's say the physician is being straightforward and honest and giving information. Possibly the patient is having a hard time understanding, or the patient is, your friend who you're advocating for has a hard time fully knowing what is the best thing for them at that time. And you're just helping them. The difficulty, of course, with advocacy is you're there specifically for that person and that person only. And your role is to be very private and yet at the same time very kind, because if you're going to get medical treatment for someone, you better be kind. You can't be mean to people, but you have to be assertive. A support person who can help the person stands up for their rights. They obtain and they maintain opportunities. They gain access to the support services, and they talk with the healthcare providers, and everything is confidential. So as I say, some people, this is not something that they should be doing or that they would feel called to do. And for other people, it's a very important thing to take on advocacy. I'll give you an example. Let's say there's somebody in your parish and that person has significant health problems and they're very elderly and they don't have family anymore in that community. So therefore, you realize that probably the best thing you could do is spend some time with that person when they're needing to visit for their healthcare needs. Now, why is that? Because you're then supporting them in the fact that they're going to receive the care that is best for them and what they need. You can't make decisions for people, but you can certainly be a support for someone. You must be a good communicator and you must ask lots of questions. The thing about being a good advocate, and this is probably the most important thing, is be a good listener. Listening is often the most important thing you can do. You must be courteous and respectful and assertive. When we're talking about issues around medical treatment, I say that again, that sometimes people are very rude to their medical professionals, sometimes, and the medical professional will say, sometimes the medical professional might have totally different ideas about you for whatever reason. The fact of it is that you must be very respectful and courteous because you're there not for your purposes, you're there for the person you're representing and advocating for. We must discuss expectations. Now, when I'm saying discuss it, I'm saying you're part of that is the fact that you're there. But the fact of it is the discussion is really with the person you're advocating for and the physician. And you want to make sure that that's how it's seen. It's not that they're discussing. You don't want to be the person who's some intermediary. You want to be the person who's simply supporting, right? There needs to be a willingness and comfortableness with advocacy, because if you're not, it's not going to work well and it's not going to be as helpful. You need written permission. We have actually a sample form that we put in the booklet that would be important to use. It's near the back of that section. It might not be perfect for your state, but the idea is that you're not just there. There's an advocacy agreement, so the physician knows, the nurses know you're there. to be with this person, and that's all you're doing, but they've asked you to be there, and hopefully you recognize as having a right to be there. The advocate talks with the person. The advocate supports them, and they act on behalf of them. Now, when there's a healthcare proxy, this is a whole totally different thing. So in Ontario, we call it advance directive. You might have a different word for it in Utah, but what it means is that someone is acting on behalf of that person. In the case of advance directives, they only actually become a legal document in the case of representing and making decisions for somebody when that person becomes incompetent. When somebody is competent, meaning they're capable of making decisions for themselves, the advance directive that they might have signed. Now, I should actually ask Catherine, do they call it an advance directive in Utah, or do they use a different word?
I think you're fine to use that phrase, Alex.
Yeah, or, you know, some places it's a living will, sometimes they're a representation agreement. Also, every state has different documents. So for instance, Euthanasia Prevention Coalition sells a basic document that's good for most places, but Utah might have a different format. I know that a lot of the state right to life groups also have formats for advanced directives, and we can get into that also with you. The idea, though, is a healthcare proxy is that you're representing somebody. And in the case of someone who's competent, being an advocate means that all the decisions are being made by that person who's competent. You're simply an assistance to them. You're being there, you're supporting them. You are a significant community to them. Now, this is most often done by, let's say, a daughter or a son. So if in the case of Catherine being a physician, she probably meets people with their children or a sibling or a family member with them. But in this case, we recognize that some people don't have family members who can do that role. And the reason is there isn't a family member who now lives in their community anymore. And we are therefore then acting with them if they've agreed to it, right? Some people need an advocate. It's important to do it. Before the visit. Now, it's very important, these issues about before the visit, because you're helping them we wrote down time and day. It's important to know what time the medical meeting will be, it's important to gather information. It's important to help this person have a list of their medicines. Now, the physician might know exactly which medicines this person is receiving. It's important that if someone's having medical issues, that the doctor that they're meeting with, or the nurse practitioner, or whoever it is, has some idea that these are the list of medications that they're already receiving. If this is an issue, right? If there's an issue of reactions to medications, or there's some health issues that might require this discussion, you inform the doctor's office of your role, and of course, be willing to wait to see the physician like any patient would, because you're there with the patient, for the patient. It's all for the patient. As I say, often this is something that a son or a daughter would do, and a lot of people don't have a son or a daughter that lives with them in their area. What do we need to accomplish? Well, what are the person's concerns? What are the issues? What are the person's medication side effects? There might be side effects. Does this person have expected outcomes? These are important things to discuss ahead of time, because you're actually helping that person when they speak to the physician. So the physician is fully aware, or the nurse practitioner or the nurse, they're fully aware of what the issue is and why they're meeting that for their medical needs. They might know already, so it's not the point. It's about communicating together. They might want to discuss new symptoms. There might be a new problem happening, and how to talk to the doctor about these issues. Remember, you're being a presence of support. That's what you're being when you're an advocate. You're not there to be in control or anything like that. You keep a notebook. Now remember, if you're a nurse or a physician, these notebooks become legal documents. So we're not that. We're only doing note-taking and journaling to help that person know what happened at the meeting, because they might also have memory issues. If they don't have memory issues and they don't have any interest in it, then obviously you might not be keeping a notebook or a journal. But if you're supporting them, they might want you to, and it's a very important thing to do it to help remind them of what happened if they're having some memory issues, especially. To record particulars. What is the particular things? The physician might say, well, you're having this problem and maybe we should try this. It's important that that's kept for them as a memory. Keep a folder of written responses, this information is absolutely confidential. It must never be, it's not yours. It is the person who you're with that actually owns that. You're simply there for them. There's no other purpose for you than helping a person out, okay? If you take notes, you respect that person's privacy. You should ask questions, but don't be intimidated by anything. You always be very polite, always be professional that way. If there's some questions, can ask these questions, suggest that they provide answers. Inquire about services. Someone might need certain home care services, whatever it might be, and they might be asking about that. And if there's information sheets that might be helpful, ask for that. And making follow-up appointments, making sure that you've written down that the physicians might have said, well, we have to see you in 2 weeks, whatever that might be, that is fully aware that the person's having memory issues, that there's no questions about it. Obviously, the doctor is also making sure someone knows about their appointments. Fill any prescriptions. So you're going with that person, you're helping them fill their prescriptions, you're helping them make sure they know exactly what's happening. You're going with them, you're a support for them. You're not filling the prescription, obviously, you're with them, you're helping them do these things if they're having difficulty with that. And you discuss that appointment with the person. We try and make things as positive as possible. As an advocate, you're invaluable in helping make our world a better place for those in need. As I say, in a lot of cases, there'll be somebody who has family who's an advocate for them, and sometimes people have nobody. In the case of someone who has developed certain disabilities, or they've got certain difficult health problems, it can be very helpful. The Advocate's Code of Conduct, I will practice with compassion and respect. This is in your book, with the person with whom I'm working with. My primary commitments are to promote the health, safety, and rights of the person. I'll be transparent in my work with the person. I will maintain privacy on behalf of that person and keep confidential all activities and all records. I will guide and assist the person in medical decision-making, but at no time will I make decisions about health or medical care or medical services on their behalf. Remember, we're talking about a competent person. I will respect that person's values and belief system as the foundation for their decision-making. We're respecting that person. So this isn't for everybody. Advocacy. Somebody might say that this is a very important thing to do and recognize that. You might recognize that you have a neighbor, someone who you know quite well, and they have issues around loneliness because they really don't have a lot of significant community, and you hear that they're having significant health problems. If they're willing and you're willing to help them, you can be of great benefit to them, so long as you recognize your role and keep that clear. In the case of someone who actually has made you their power of attorney for healthcare, that means when that person would become incompetent, that you make healthcare decisions for them. It's very important that you have there'll be a written agreement ahead of time, such as what we sell, Euthanasia Prevention Coalition has what we call the life protecting power of attorney for personal care. But it's also very important that you have discussed it ahead of time with that person, so you know their values, right? Because you're representing them. It's not about what you think, it's how you represent them and protect that person. Now, in the case of someone who's a member of your church, obviously speaking, it's very likely that they're going to share your values. Now, here's an important point. I mentioned about power of attorney documents, and I might have mentioned in the last situation too. A lot of people will assign, as I say, their eldest daughter or their eldest son to be their power of attorney for finances, their power of attorney, for property, right? And for healthcare and things like that. And they then sign their will, and they have a separate will, and they've assigned like the eldest child to do these things for them. And they think everything's fine and good. And it might be fine and good, but if someone doesn't share your values, when we're talking about healthcare questions and your health, it's important to assign somebody to make those decisions for you when if you become incompetent, who actually shares your values, because they have a lot of power when someone becomes incompetent. So if you've appointed someone to make decisions for you based on a power of attorney, when you become incompetent, they actually have a fair amount of power, and you want them to make decisions that you would want to have made on your behalf. So it's not only discussing it with that person ahead of time, but it's also appointing someone who you know will make decisions on your best interest on your behalf as you would want. Okay. And I say that very clearly because I know I get these phone calls from one of the daughters and they say, yes, mom picked so-and-so as a daughter. What are we going to do? Because this is what's happening. And of course, the reality is if you have no legal right to do anything to help mom, then you have to talk very nicely to the person who is the power of attorney to help that convince them to make the right decision for your mom, right? This is the kind of situations that I get calls about all the time. Elder abuse and other problems. Well, if you're going to be visiting elders, you're going to notice at times, and sadly, it's too often, you're going to notice at times that someone actually is showing some signs of abuse. I became the caregiver, or not the caregiver, the legal decision maker for somebody here in my city who I knew very, very well, an elderly person who I had incredible respect for, an amazing man. My wife actually wrote the book about him, and an incredible man. Anyway, in his very elderly years, I was appointed to be his decision maker, and I helped him an awful lot. But there was a serious problem in that family with elder abuse. There was a serious problem. This was not a pleasant experience for me to have to deal with all the time, because here's a man who loved his children, thoroughly loved his children. And he had a couple of his children who were really taking advantage of him. It was very not a nice situation. Anyway, so, you know, these are the kind of things I hope you don't bump into, but you might bump into. And how do we deal with these things? Well, there's signs of abuse, and hopefully you never bump into this, because you could be visiting some nice lady in your parish, and she's on the list of someone who you know should be visited, and Father's giving you this list, so you have a list, and you call her up ahead of time. She says, oh yes, she'd love to see you. You can visit her, you're talking to her, and you're noticing some things that just don't seem appropriate. This is a very difficult situation, isn't it? And how do we deal with it? It's, well, like for instance, sores and injuries, you might not be able to see that easily because they might be covered, like they might wear long sleeves all the time because they have a son or a daughter who's done something to them, or a neighbor or someone. And they don't have any reasons for the injury. Now you might say, oh, they fell down. But if you go there 3 weeks later to visit again, and there seems to be another injury, this seems to be a problem, right? It's very difficult. So not seeking care for an injury is also a sign. They're messy and unclean in appearance. Well, that may or may not be. People sometimes, when they become elderly, become less concerned about how they keep themselves in appearance, but nonetheless, it could be a sign. Malnutrition and weight loss is certainly a sign. Dehydration is absolutely a sign. If they're afraid of someone, that's certainly a sign. The biggest form of abuse, though, is financial fraud. Someone who you know had a very good life, they did very well for themselves, and they have literally nothing left. Sometimes you have to wonder who took it from them. And these are the kind of things you might bump into. Exploitation, sexual abuse, you might not hear about that unless someone wants to talk about it. That's less likely that someone will talk about that. Not to say that they won't. These are the kind of things we bump into. Not that I want you to experience all these terrible things. What I'm saying is you might bump into that. Physical abuse is an act of violence that may result in pain, injury, impairment, or disease. Neglect, failure to provide goods or services necessary for functioning or to avoid harm. So you might see issues around neglect. You might see things around physical abuse. You know, they have signs of abuse and they've not contacted a healthcare provider. They've not contacted a doctor about something that's happened to them. They have a wound that's that might be infected. These are signs of neglect or abuse. The person has not received any medical care. Most common injuries are bruises, pressure sores, and fractures. These are the kind of things. Now, bruises might happen more easily to an older person just because of how their body is. Nonetheless, you might see these type of injuries that come along. I'm not trying to scare you. I'm just talking about reality. And there might be some injuries involved in the outer layer of the skin. This could be just caused by movement, but it could also be that they were treated very roughly. So there's an evidence then of both the physical abuse and neglect in that case. Bruises happen when a blood vessel ruptures and the blood escapes into the surrounding tissue, okay? This may suggest that there was an injury, and the common location of a non-accidental injury might be a face or a neck or these kind of things, but you may notice these things. This is to say if they have it on their arm or something, they might always wear a long top to cover it. It doesn't mean that it was abuse, but it could very well be. You can notice if you're visiting someone regularly and you notice these things, that becomes a big thing. Results from tissue exposed from, so you could have a burn that results from a tissue burn. It's, you know, someone, if they touch the stove or something else happened to them. Categorized by how much surface area. So if it's a first degree, you know, if you have a different type of, the worse the burn is, it's based on the amount of surface area that was damaged. So in persons over 65 have double the national death rate from burns than someone who's younger. So if you're 65, you're twice as likely to die from a burn than if you were younger. If you're 75, the data says you're 3 times as likely to die from a burn. I mean, a serious burn, I'm not talking about. And 85, you're 4 times as likely. So you see how the body doesn't heal the same way or reacts in a more extreme way from a burn. Fractures occur when an external force greater than the strength of the bone is applied. Okay, and older people are more susceptible to injuries in bone with bone disease, or if they become more brittle in their whole body makeup. And common sites might be a hip or a wrist. Someone pulls on them or things like that. So elderly people are at risk of a spontaneous fracture also. Lacerations are usually result from a blunt force, and they're characterized by the splitting of the skin, and they're common in physical abuse, but they can occur also with neglect. It might happen with a fall, but I'm saying if you notice someone experiencing something it seems to be that this is a regular thing for them, then we're concerned about abuse. Pressure sores, inadequate blood supply. Now, pressure sores often are more common though if someone is how would you say, not moved around a lot. If they're in a bed, or let's say they're put in a wheelchair and they're not being moved around, so they get a pressure sore from neglect if they're not actually being properly cared for. And so often pressure sores can be a serious problem for somebody. And that's why, you know, when you're talking about proper care of someone who, let's say, has more serious mobility issues, they talk about the importance of turning somebody, right? Because you don't want to have these pressure sore issues. Restraints. Abuse or neglect can be related to restraints also. A person is restrained in a non-critical, if it's a non-critical situation of being restrained. You know, restraints can be a problem and sometimes it's seen as necessary, but I think that the whole medical professional world is moving away as much as possible from the concept of restraints, because in fact, it doesn't necessarily do what they're talking about. If you're talking about people with disabilities, the concept in the past was if someone had a difficulty being cared for, they were often restrained. And this is something that was, you know, thankfully more so in the past. Today, we recognize that that does not help the behaviors, that in fact, what we've done is we've treated someone in a less than human manner. It might be necessary to do that someone might be in a restraint, but really this is something that is really not seen in the same light as it was years ago. And I think that's good. Restraints can be a serious problem. We shouldn't be treating people that way. And I'm not saying that it's never necessary. I'm saying that you don't treat human people this way if at all possible. In sites, you see skin tears, so in spots around their arms or legs, multiple tears, abrasions. This is raising suspicions. Skin tears do heal without scarring usually. So there's often a marker of neglect is malnutrition. There's you know, it's been very sad. Like the articles, I don't know if there's been research done in Utah about some of the difficulties that have happened in nursing homes, but it's been a real shocker in Ontario, the reports that have been written now about some of the neglect that was happening, especially during the COVID pandemic in our nursing homes, especially early on when a lot of the staff were sick. You didn't have visiting going on. they talked about the amount of malnutrition that was going on. And at first, of course, people were reacting to it, but now what happened is there were some serious death problems going on in certain nursing homes. And in the end, the government had to do these reports to figure out what happened, what went wrong, how do we avoid this? Some of these reports are really hard to read. So that's in our government homes in our province of Ontario. I don't know what happened in Utah. I know that in some places in my province here of Ontario, some very terrible things occurred. And there could be many reasons for it. The staffing issues. Part of it could also be that there were issues of management in that location. Some of it could be that they were overwhelmed by the sickness. It's all true. There's many reasons, but things happen that should have never happened. And we're talking about it now. This actual slide and program was sort of put together before COVID was ever even an issue. And yet we know malnutrition is a problem. For instance, in a lot of places, they need volunteers to feed people because someone can't properly feed themselves. And yet at the same time, if you don't have family coming in to do feeding, let me give you a straight thing. I got a phone call from a woman from Alberta, and they had her mother-in-law had certain levels of dementia and was in a care home, and she was going in every day to feed her mother-in-law. Now, that doesn't mean that everybody in that care home had a daughter-in-law coming to feed them every day. And I'm not saying that everyone was experiencing difficulties. I'm saying in this case, she was specifically doing this. And then, of course, you had this COVID outbreak, and they were denied access to go visit her mother-in-law. And her mother-in-law went down very quick. And so she called very upset after her mother-in-law died and wanted to talk about this and this whole situation. And I don't know what to say. All you can do is listen to someone who's talking about these terrible things that happened to them. Of course, they were convinced that it was an issue of neglect and they wanted to know what to do about it. The difficulty is in these times around COVID, it's really hard to deal with these things simply because a lot of problems happened in a way that we would have never expected would have happened a few years ago. And that's a nice way of putting it. Signs and symptoms: dehydration, confusion, sleepiness. People who are experiencing dehydration, they often are reacting differently to their medications because of the decreased absorption. So dehydration becomes a serious problem. People just, they're not being properly cared for. And dehydration is a serious effect, more so, of course, dehydration than malnutrition. Dehydration has a greater effect on the person's ability to react. They may not recognize that they are being abused. They may not be able to report the abuse or talk about it, and they may not be believed. So that means somebody might have to actually bring it up and ask questions, because it could be something that you're noticing. If you're noticing on a regular, it's important to ask questions. I'm not saying you will ever bump into this. I'm just saying if you did, you're dealing with a person who may not be willing to report the situation themselves. I'll give you a little example. My mother-in-law was in a very good nursing home, actually. She died a couple of years ago. Anyway, she was having a serious problem with one of the orderlies. One of the people, staff working there, was taking things from her, was intentionally not returning her clothes to her after they were laundered, was causing all these sort of difficulties. And she was telling us about this, but for some reason she wasn't telling the staff about it. And I don't know why she wasn't telling the staff about it, but she was talking to my wife about it. She was saying, and it's only this person who's doing this, okay? So my wife called up the nursing home and said, my mother-in-law just told me this, and this, and this. And it's only this person. Please do something about it. My mother-in-law never saw that lady again. She never came back again to that room. I don't know if she was fired. I've got no idea. It was none of our business. They never called us and said, oh, by the way, we let that lady go. We don't know. But she was not willing to tell the others that she was experiencing this. Now, this wasn't the type of abuse of physical abuse. This was This is a different type of thing, like things being taken, your clothes not being returned, this crazy things, that didn't make any sense. Self-neglect also accompanies, though, if someone has dementia and mental health issues. So this makes a victim more vulnerable, but sometimes there's other issues. People become dependent on others. And so therefore, often when they're dependent on others, they won't report. The biggest problem with abuse, though, is it's family members often, or friends who are often the abuser. And the person will not then report the abuse because they love their son, they love their daughter, this friend of theirs or somebody, there's a situation, they don't want to report the abuse. They may not even talk about the abuse. Often it's financial abuse where, you give somebody, or let's say they take $50 out of their account. Often if they're in a nursing home, they have some sort of account in that nursing home so they can have money to buy gifts for people or do different things with their money. And someone's taking it from them. Things like that, they're always having this issue, and you might come upon this. Abuse and neglect leads to depression, which in turn leads to also self-neglect at times. Alcohol abuse is experienced by 5% of older persons. Now, obviously, that's just a ballpark figure. It's more common in men than women. And financial abuse, widowers in their 70s or 80s living in the community, it's considered the crime of the 21st century. A lot of our older population did fairly well. They have some financial resources, and in their older age, some of them are being taken advantage of for sure by family members and others. And the compassionate community care information. Now, there's some Canadians on this call and some non-Canadians. Now, we have some questions here. It is right now 10 o'clock, so our timing wasn't so bad. I'm going to look at the chat.
I think you have to stop share.
Oh, I have to stop share. You're right, Genevieve. Thank you so much. I'm going to look at the chat. Utah ranks the fourth worst in the country in elder abuse. Well, maybe you're actually one of the best in the country for reporting it. That could be it. Nonetheless, elder abuse sadly is a common problem. Please speak about the legal obligation to report. Absolutely, Charbel. So that's what we're trying to get to. When you're actually helping somebody, it gets into a difficulty situation because you have to be willing then, if you're actually noticing abuse, it has to be reported. So in the case of the man I was helping out, the sad thing is when I recognized there's a serious problem and I actually contacted the police about it. Their response was, because I was the legal authority, he had signed legal authority over to me, so I was in the right to talk to the police. They said, "Oh, well, we have a file here on him." So I wasn't the first to report that this was happening to him. Sadly, I was not the first to report. Anyway, so this was the problem, and how I dealt with it is, it was essentially the biggest thing. He wasn't physically abused in any way, actually, no, it was financial abuse in a huge way. And what I did is I just took care of all of his bills. I took care of all of that. Any money that came in was then, I had control over. And then I had someone helping him do his grocery shopping. So he had all his groceries, all of his bills were paid. And I just took care of all of it for him, as much of it as that was a bit of a difficulty, because that sort of dried up the source of the money. I was then in control. There was no happiness for Alex, I'll tell you that much, but it did make a difference. It did make a difference.
It's also important, if you start recognizing things that you might think is abuse, but you're not sure, it's a good idea to write down what kind of abuse you think you're seeing and when you're seeing it, just to have a record and for when you do take it to the police, if it becomes a habit that you're seeing.
The message by Catherine, the Diocese of Salt Lake does have advanced directive information. So that's important because that's for people in Utah. As I say, we have similar documents here for Canadians, and the language of the document is what's essential, because when someone is becoming incompetent, the language of the document is actually like what you believe your values to be and what you would want and not want. So it's sort of important that you not only appoint someone who makes decisions for you, but the document is written in such a way to represent your values, right? Alex, what do you do if you're serving as an advocate and they learn they specifically want physician-assisted suicide or euthanasia? Well, you can't actually participate in that. You can't do that. This becomes a very difficult situation. Now, we have a problem in Ontario. So first of all, we're not talking about people who are medical professionals per se. Like if you're talking about a physician situation, if Catherine were a physician in Ontario, she's got a problem. In Ontario, the College of Physicians requires physicians to do what they call an effective referral. So if she had a patient come to her in Ontario saying, I want euthanasia, and they call it MAID here, right? Medical aid in dying, to make us all feel better about it, she would be forced to refer her patient to the killer. Now, the physicians in Ontario who aren't willing to do that have been fighting for their conscience rights, and they're saying, I'm not going to do that. Nonetheless, the college requires that. And so the fear is, would they get dragged before the college because they refuse to send their patient to the killer? This is this is the big battle right now over that issue. In the case of someone who's an advocate, we're not physicians, we're not nurses, we're a friend, and we simply would say, you know, as much as I'm happy to visit with you, I totally disagree with that, and I will not participate in that. You have to be willing to stand up for your own beliefs. You have to recognize that you have a conscience that you need to exercise with. The other thing is, I'll give you another example. I had a case of someone who was being talked into euthanasia. I can tell you the story very quick. The town that I grew up in, I have a friend who is a close friend of mine, and her long lost sister from Vancouver showed up when she found out her mother had cancer and was dying. Her mother was dying. She was terminal. There was no question about it. But her sister, who she had not seen in 10 years, now she shows up at home, and her sister's all pro-euthanasia, trying to convince mom to have euthanasia. So I get a call from my friend saying, there's this disaster here. My sister has shown up. Mom's fine. You know, she's been the dutiful daughter. She's been helping out. Mom's fine. Yes, she is terminal. No question about it. Now my sister is convincing my mom towards euthanasia. So what happened is I said, take her to the local hospice. Take your mother to the local hospice, because I knew what the local hospice was like. It was actually a very good one there. Very, very good. I wish that were for all of them. Sadly, some hospices, now that we have euthanasia, it's legal. It's the same problem if you legalize assisted suicide in Utah. Some hospices are going to change. Well, some hospices in Ontario have changed. Anyway, I knew the one in my hometown had not changed. They were truly a hospice. So she went there with her mother to the hospice, and the hospice was very clear. If you're thinking about euthanasia, don't come here. We're not going to do it, and we're not going to participate. And her mother said, thank you very much. I'm not interested in euthanasia. Her mother died a natural death, and there was no problems. Her mother had a fine. She was cared for properly. There were no issues. And you have to do the same thing with someone if you're coming to the same thing. Let's say someone has some ideas that you totally believe are wrong. You have to express that, right? You have to express that. The elder abuse system in Ontario seems to be a circular file. Comment from Ruth. There seems to be a serious problem in Ontario. I would agree with you, not only with elder abuse and other issues like that. I talked about the senior care homes issue in Ontario. I could cry about it. I read that report. It was upsetting. How could this happen? How could they even dream about doing this to people? Anyway, I talk about this child. I'm telling you about this child. I don't want to get into all the issues of this 3-year-old girl with significant brain issues. Like, obviously she's got cognitive issues. There's no one questioning that. But why do they have to treat this girl like that? It's insane. And I don't want to get into it further because some of you won't sleep at night. Being a CC person on a senior care home is like being a monitor of the situation overall. Where actually it's important. See, why would we be visiting somebody? Or if they're in a care home or if they're in their own home, it doesn't matter. You're visiting them because you're being with them. So you're sharing yourself with them. In the case of this being something being done in a parish model, you're visiting somebody and then in your parish community, but you're sharing your life with them because you know they're a human being. So you're not only then being a monitor of the situation, you're actually being someone who they look at as that significant other for so-and-so. So as an example, and I know this is, I don't know who Ruth's iPhone is, but anyway, I'll use the name Ruth. If Ruth were in a care home and Genevieve's visiting Ruth on a regular basis, the staff would notice this Genevieve comes around to visit Ruth on a regular basis. While they see Ruth as having significant community. She's an important person. She has community. It's an important thing. Someone might want to undo their mute if they want. You can leave questions in the chat, but I think I've dealt with all the questions. So actually what you're doing is you're actually affirming that person. You're affirming them in many ways. You're helping them in the sense that they might be going through depression and loneliness, which is normal. It's normal. But on top of it, you're also affirming the importance of that person to others. Yeah, does anybody want to ask a question? You can actually, you're capable of unmuting if you want. And we have about 22 minutes. Does someone have some experience they want to share with us? Because some of you might have done some.
Alex?
Yes, sure.
Can I ask an important question about elderly abuse from a legal perspective? When it comes to elderly abuse, and if an elderly abused by those who have the power of attorney, can they lose their status as power of attorney, and whose responsibility become when the elderly abuse happen in home, not in the long-term care or facilities?
So you're bringing up an important legal question, and I can tell you in Ontario, now things might be totally different in Utah. We have something called a consent and capacity board. So if you were to question the power of attorney, so let's say, Charbel, it's a family member and it's in your family. I'm not saying it is, I'm just using it as an example. You would then challenge that person's right to be a power of attorney, and that would then be heard by the judge or the tribunal in the consent and capacity board. The problem is if the person you're representing is incompetent, now the difficulty is who do you appoint as the next power of attorney? The law says that it's usually the closest family member. So as an example, if you're talking about my mother and and my mother has 5 sons, and let's say one of the sons is the power of attorney and we're questioning the decisions being made by that one son, then if they were to replace her son, my brother, as an example, that would be then they would replace with one of the other brothers usually because we're the closest kin. That's how it would be done. But sometimes it would be someone appointed by the government. I don't know how good a deal that is actually, but that's sometimes all you can do. If sometimes it would be a government appointee in those cases.
But has nothing to do with the will. That they lose it if the will has already been written.
Well, the problem is you're talking about a power of attorney in this case because the person's incompetent and that someone's making decisions for them. Anyway, we can talk about it at another time, Charbel, but the difficulty is yes, you can challenge them. The question then becomes who becomes the next person. And remember, these documents are only legal in place if somebody becomes incompetent, right? If you're fully competent, what I don't like is I often notice people, and I'll give you the prime example. When I visit my mother-in-law, you notice that there's people who are actually quite still competent. But they're not making decisions for themselves anymore because for some reason the decision-making power has been given to the daughter or the power of attorney prematurely. And I think that's an error. I think that if someone's competent, that they should always be respected as the decision maker. It's when they're incompetent the question should come in. And I think we get problems when somebody else starts taking the legal power when somebody else is still competent. Okay.
This week I was in a capacity assessment with an elder because I'm an interpreter, and they deem this elderly man he cannot make decisions. They give him automatically his daughter.
But can we talk about this later, Charbel? Because I think Cynthia wants to ask a question also.
Okay, apologize. Sorry.
No, that's okay. I didn't have my hand up. That's
It's
all right.
Gary that did.
Yeah.
Gary that does. I'm going to ask you to unmute Gary. It's not Gary, but it's Gary's name on there.
I know, because he signed up. So I had a comment. I have 2 comments. So one, when we did our power of attorney for finances and for health, the lawyer, she was actually an attorney for the, I don't know, some elderly group here in Kingston, Ontario. And she said with all the abuse cases that she's seen, you've got to sit down and talk to this one, and this one to see who your power of attorney is going to be. And she said that our power of attorney for finances is the most important paper that we've ever signed in our life. And she said, it stays with me because when you sign it, whoever you've named right at that moment is allowed to do anything with your finances, whether you're competent or not.
I know
So-
the power of attorney for finances is another issue. In Ontario,
Yeah.
I don't know how it is in Utah, but in Ontario,
Yeah.
you're right.
And then for the power of attorney for health, just I'm a nurse, or I'm retired, and we had an in-service with our hospital lawyer one time, and she was talking about power of attorney for health. And she was talking about this one case that they had. So it was two best friends, two women who had been best friends all their lives. And they would go to dinner or lunch, whatever. And they would say, you know, oh my God, if I ever have a stroke, just let me go, let me go. And one of them had a stroke and the other was the power of attorney. And when they went to the hospital, she kept saying, let her go, let her go. And all she needed to do was get that TP whatever, and she would have been perfectly fine. And her friend kept saying, nope, she said, let her go, let her go. So they didn't give it to her because she had the power to say that. This woman recovered, but not to the point, you know, that she was fine. She had some disabilities. So she actually had to sue her friend to get money to revamp her house. So the point that this lawyer was making was that you have to go through every single scenario that you can possibly do. So I had said to I had my sister, my oldest daughter, and my best friend. And I said, if I'm in an accident on the 401 and I come in.
For those in Utah, the 401's a major highway.
Yeah, or the whatever, right? I-95, whatever. If I come into the hospital and I'm unconscious and I'm paralyzed from the waist down, what are you going to do? Well, I would have kept them all with the answers. But by the time I got to, I'm paralyzed from the neck down and they can still save me or let me go, what are you going to do? And my best friend said, do everything and save her. And it was like, no, futile care, don't want it, you're done. And I didn't put her down. So, and that I only learned that from that lawyer, right? You really, really, really have to discuss everything when you're putting a person down for that, not just say, well, this is what I want. But what do you mean exactly by that? Very important.
So as I say, you have to choose someone who shares your values. And obviously speaking, that we're not obligated to receive all medical treatment at all times, for sure. Nonetheless, if as you said about the person with a stroke, if I'm capable of receiving treatment that's effective for me, I'm of the opinion that effective treatments I should always say yes to. Absolutely. It's only when it becomes really questionable, or how would you say, it becomes very burdensome, the treatment, then I should be really questioning whether or not that should be continued or not. But anyway, these are important things to talk about. In the case of doing this visiting, you're probably not going to be the power of attorney of that person. You're probably just visiting that person. If you become an advocate, though, that might be a different story. If you're advocating for someone, you might then become their power of attorney for healthcare, etc. And that becomes a different issue, obviously. Yes, Catherine.
So this might be a time to maybe, Alex, if you want to talk just briefly about, and I can talk about the Utah situation, but can you talk briefly about POLST versus Advanced Directive?
Okay, so in the US, you have these issues around POLST as compared to advanced directives. A POLST is something that is around end-of-life treatment, and it's usually oriented towards someone saying no to certain medical treatments, whereas an advanced directive is a little different, because an advanced directive does two things. It does list your values, but it also appoints someone who would make decisions for you when you can't make decisions for yourself. The problem with POLST, Catherine, is every state's a little different. Like you might have a certain POLST or MOLST or whatever form in Utah that's totally different than what's in Massachusetts. And so it becomes a little bit difficult in the US. It's the same thing in Canada. We have different laws around power of attorneys in each province, around these documents and these issues. But In Canada, it's fairly standardized, other than British Columbia and Quebec. It's fairly standard, okay? Most of them follow the identical model, except for, as I say, British Columbia and Quebec. In the US, you have all different types of forms. Why is it important to have a power of attorney that you appoint? It's important to have someone who can actually make decisions for you when you can't make decisions for yourself, and who has the legal right to do so. Now in Utah, I'm assuming that's legally allowed, that you've assigned a person. And how I always tell people to do it is in the documents, usually you have someone you're appointing, and then you have a substitute attorney. The idea of the substitute attorney or the alternate attorney is if someone you appointed is incapable of doing so. So let's say you had a car accident and you're with your husband in the car accident, and your husband's your power of attorney. Obviously, your husband can't make decisions for you because both of you had a major car accident. At that moment, it might only be for a day or two. At that moment, both of you cannot respond. So then usually when you have these documents, you've appointed your power of attorney, but you've also appointed an alternate. And the alternate only then comes into being when your power of attorney can't represent you. Okay. But once again, you should only appoint people you will trust will make decisions that you would agree with. And I say that very clearly because we live in a world today where a lot of people, they did a wonderful job in raising their children, but for some reason, some of their children went a whole different direction and don't believe in their values at all. You can't give that person the power over your life and death when you're incompetent. You can't do that. Not that you don't love them. And not that they're terrible people per se either. It's just that they don't share your values. So you don't appoint them. You appoint someone who does show your values, because you want to make sure that if Catherine's your physician, she's saying, has your mom ever talked to you about this? And you would say, yes, this is what we want. And this is what she has said before. And I've got the legal document here, and these are our values. And we can be pretty sure that that's what we're going to do then. Sometimes you get disagreement though, and that's the problem. I tell people, don't appoint 2 power of attorneys for you. Only appoint 1, and then you would have then an alternate. Why do I say that? Now in Ontario, you can appoint 2. I don't know if you can in Utah, but in Ontario, you can appoint 2, and they can either make decisions together or make them separately. And I think that's crazy, because these documents only come into place when I'm incompetent. I don't need someone fighting over my medical treatment decisions when I'm incompetent. Like, I don't need that. You appoint the person who you trust, and then the other person is your alternate.
I have a situation right now in Ontario with my brother. He is power of attorney of my mother, who has Alzheimer's. And my mother is a Catholic, a devout Catholic. My brother, not so much. And so at this point, has she decided that, that she would want to die naturally? Does that have to be said or written down, or is it just assumed unless she does the contrary by making a document that says, I would like to have euthanasia if something happens?
As you know, Cynthia, at this moment, this is the euthanasia question for Canada. At this moment, she can't legally request it in her power of attorney. Now, you said she has dementia, so I'm assuming, is she incompetent now, or does she still have levels of
That's a good question. I'm not getting good communication with him at the moment. And so I was just worried that if he decided that he would like euthanasia, would that be within his power as a power of attorney?
Decide that. But as you may realize, if you read my stuff, that's what's being debated right now in Canada. If you're in Utah, think about this. We're debating right now in Canada that people who are incompetent, that someone else can make the decision, or that you could pre-decide. So let's say when you're 55 years old and feeling vital, you could put down there, if I had dementia, please kill me by euthanasia. That if I had dementia, now you would lose the right to change your mind, because the document says it's now in place. They would do it. Right. This is the kind of thing we're talking about right now in Canada. I think we've gone to a place of insanity, but that's my belief. As for your mother, no. If she is incompetent, they can't do that to her at this time in history.
Right.
No,
okay.
The law does not allow that. No.
Okay, so it wouldn't be a situation where I have to fight my brother because I know she's Catholic and she would want to.
Your greater concern is what we call basic care. So a lot of people make the decision that mom has dementia. It's gotten to this point. We're just not going to feed mom anymore. We're going to give her some. It's terrible, but some people are doing this. They give mom some sedatives, so now she's sleeping, and then over 11 or 12 days she dehydrates to death. They call it a natural death.
Yeah.
I wish that weren't happening, but it is happening. And
I'm sending all your movies and everything to him and his partner to educate them. And yeah,
anyway,
good job
and I wish
in the
they did.
movie.
I know Greg's got his hand up. Can you unmute yourself? I can ask to unmute you. Anyway, there's someone with a phone number that has their hand up. If you unmute yourself, your phone number is 289 something. You can ask a question.
Yes, thank you very much for the informative talk, Alex and Genevieve. I'm wondering if, and hopefully I'm wrong, if there's an inkling that there could be elder abuse based on nonverbals, is there an ideal way to broach the subject?
Well, as you know, talking about these issues are very difficult, and the only way to actually broach the subject with someone is if you actually have a relationship with them. Because usually abuse happens by someone close to them. Usually that's what it is. Rarely is abuse happening by someone who has, very little life contact with that person. So when I referred to my mother-in-law's situation, it was the one orderly, whether she was a nurse or an orderly, I think she was an orderly, who was obviously causing her difficulties. She probably didn't want to talk about it because she was probably thinking, if I talk about this, it's only going to get worse. Maybe that's what it was. She was thinking, it's not so bad. I'm really ticked off about it, but whatever. She did tell my wife about it. And then of course my wife dealt with it. But if you have a relationship, and that's the whole thing about visiting, if someone trusts you, they might share these things. And if, let's say, they regularly having cuts, and you notice that there's some problem, like they've been sort of like yanked, and you're noticing there's a problem, you might want to ask them. They might give you an excuse. But if it's happening all the time, at some point, someone's got to step in and say, I think something's happening, please tell me. I want to help you. They might not admit to it, though. There's nothing easy about these situations, is there?
No, that's for sure.
But it is.
Thank you so much for this talk, though.
Yeah. Are there any other questions?
God bless you.
Thank you very much. It's 10:25. So we did send the booklets to everybody, and you have that. The whole thing is, we really do encourage you that if you are in a parish community and this is something that the parish is willing to do, and you talk to your parish community about it, and they like the idea, doing the My Story with your community. So then you get others who are trained to go visit, because first of all, the idea of the My Story gives you an ability to get in to speak to people. So we're drawing up a list of, well, who's in our community who's older, who is alone, who could use visiting, but who are these people? And then they might say, well, why does so-and-so want to visit me? I want to talk to you about your story. I want to talk to you. You have something to share, and we're interested. Now, of course, everything is voluntary. They don't have to do anything, but if they want to share their stories, you're really affirming someone's importance in their life. But the other thing is we're helping someone, and at the same time as we're recording our history. It's quite important. And you're creating a reason for them to say, yes, please come and see me. This is a good thing. So in my hometown, my mother's been doing this. My mother's a great woman, actually. She's an amazing woman. And so my mother's been doing this. And so she has been a little bit shocked by some stories she's been told by people who, they were happy to speak to my mom. My mom's someone who a lot of people trust because she's been visiting people for so many years. She's been doing this forever. I mean, visiting. As I say, when she started visiting people, no one talked about needing a training program because, you just went to visit. You were given a name and off you went to visit, and that's what you did. But anyway, so there are people who did open up to their own stories, which were not very pleasant, but then there's other people who have amazing stories of the things they've done, and to share that with the community in general. And obviously these sad stories, we don't necessarily, there's privacy, people probably don't want to share that in the general public, but it is helpful for them to talk about it, especially if it's with someone they trust. And remember, privacy is a primary focus for all of us. But why are we doing this? We're doing this because we recognize the nature of the human person is someone who is created to be social, and we recognize the difficulty we have in our culture of severe loneliness. And I notice in Canada that is a primary risk factor for euthanasia. Primary, not secondary, not third. The euthanasia lobby talks about pain and suffering, and they wave the flag, and they have these horrible stories they want to share with us. And some of those stories absolutely are true. Some people have gone through bad situations. I'm not going to argue with that. That's true. But the reality for most people is not that. The reality for most people is that they are, yes, they're going through a difficult time, but they are really feeling hopeless in their life. They're feeling no purpose. And so this isn't, you don't have to legalize assisted suicide to be someone in a situation where they become vulnerable. Then, you know, they feel their life has lost purpose. They feel a lack of hope. And so we're seeing the suicide rates in those situations. So a lot of people in those situations might be thinking of suicide. We hope they don't do that. We really hope they don't, but sometimes people do that. So we are helping to create reasons for someone to feel hope in their life and purpose.
And Alex, it's also very much like a psychological healing as well when you tell your story. And you know, I've done a lot of therapy work, and so I think that it's going to be very healing for them and for the rest of us who have journeyed in our own lives and, you know, are aware of our own story. We can have the opportunity now to be listeners of other stories, you know, so it's kind of a nice reciprocal change. You know, somebody has listened to us to help us heal, and now we can do the same thing.
I'm thanking you for using the term listening, because that's the primary issue. I'm doing a lot of talking, but I realize that the primary issue is listening. Yes. Yeah. And it is 10:30. You can email, I'll put it into the chat. You can email me at info@epcc.ca. All of you received an email from Genevieve, so you can email Genevieve back.